CataractCoach.com, podcast series, episode number 123 with Dr. Stephen Lash. What makes a good surgeon, and how can we become even better to improve surgical skills and outcomes? Welcome back to our Cataract Coach podcast. Today, I have a very special guest, and we're going to talk about a topic that I know for sure you want to understand better, and that is how to improve your surgical skills and how to get better outcomes. And our guest surgeon here is so well versed in this, he wrote a book on the topic. So I welcome Dr. Stephen Lash, or should I say Mr. Stephen Lash?
It is in the UK, Mr. Yeah, but you can call me whatever you like. I don't mind. Thank you for that kind introduction. I'm not sure I'm an expert. I'm more of a journeyer on this, so I'm happy to share my findings.
Well, I think we're all experts to a degree because we all have a passion. I read your biography, and what I liked was that you said, I am passionate about eye surgery. And I think a common thread among ophthalmologists. So we are passionate about being better versions of ourselves.
But passion means sacrifice, rather than very enthusiastic. It means you've got to be prepared to give something up. So yeah. I hope people give something up and read the book and, take some time over it, because it's a big deal, surgery. It's a great honor and a privilege, and it's great fun. It takes some sacrifice, though, to be good.
Yeah, I can definitely confirm that tens of thousands of cataracts later, 25 years later, I still love going to the operating room.
Yeah, it's great, isn't it?
It's a happy place. Now, we'll put a link down below for your book and your website.
That's very kind.
It'll be in the description here. But tell us a little bit about the book and what caused you to write this book.
So what caused me to write it was a couple of fellows that I had. So I'm a VR surgeon. So I guess I get to help you cataract surgeons out every now and again, but not often. And these two fellows, Haytham and Mohammed, they're both from Egypt. We were doing a debrief. So I always like to do surgery. And then after surgery, we go to a well-known coffee outlet in the UK, which I won't name. And we have coffee. Coffee's essential. And then we chat about the cases. Right. And I was probably going on about molehills or surfing or something tangential to surgery, because I like to use these sort of images, metaphors, etc. And they just said, you should write a book about it. And I thought, well, I don't fancy that, but we'll give it a go. So I wrote the first chapter, sent it to them. They said, this is actually very good. And then, when you're writing a book, it took me 18 months to write it. A day a week I would just spend. And some days I drink about 20 cups of tea. And other days, there was one day I woke up, I sort of came to and it was dark. And I'd just been writing all day and hadn't realized it had gone dark. So it's a really fun exercise. But you also get to refine and think and challenge. So it helps you to go deep and to really clarify your thoughts. So I went home, wrote this chapter book, and then I thought, well, I like thinking about different perspectives. And I just drew this terrible picture of a surgeon at a table in a room. And that formed the outline of the book. So if you imagine the surgeon's hands around the patient's head, that was box one. And that was really narrowing my perspective to what happens in the moment of surgery. And so I thought about, well, how can I explore that subject? So I looked at sports psychology and sports psychology techniques.
Okay.
I looked at simulators. I looked at airline pilots. I looked at musicians, the concept of practice and virtuosity. I looked at athletes. And so some big themes came out there. And then I thought, well, the second box sits around the surgeon's head. And that's more to do with the planning of surgery. And I use Toyota car manufacturing, lean and muda, and the elimination of waste. I mean, lean's been used a lot around organizing A&E departments and various things, but not as far as I know to surgery. So I actually applied it to actual surgery.
Right.
And then I looked at, well, why wouldn't you be lean? Why would you fluff your technique? And I realized there were two big reasons. One was whether your locus of control is internal or external. So internal locus of control, everything's my fault. External locus of control, it's the patient's fault. It's the scrub nurse's fault. It's someone else's fault. It's not my fault. And then the other thing was failure. And I did a deep dive on failure from a societal perspective over the last 2,000 years. And having explored that, I reckon we live at a time which is probably the worst time in history to fail. We have cancel culture, or maybe we don't anymore, but it's certainly still there. And then I looked at the culture of medicine and compared it to aviation using a model by Goffey and Jones, which is a sort of sociological model in terms of solidarity and sociability. And I realized perhaps that as surgeons, we're in the worst sort of culture to fail: low solidarity, low sociability. And then finally, I looked at the whole self-esteem movement, which I think grew out of near your house back in LA somewhere. and how failure has now been internalized, that we've been celebrated for years as, well, certainly my kids' generation, for mediocrity. And when you fail, suddenly it's you failed. It's not what you've done that's failed. You're a failure. And then the final box is like the theatre the surgeon's in. And these are the really subtle but powerful influences, like heuristics, so the mental shortcuts we take. Look at system 1, system 2 thinking, look at complex problem solving, and then finally personality, because I was fascinated to see if surgeons have a certain surgical personality, and they appear to. They do. Yeah. Thankfully, I have it. So that's a relief. And actually, most of my fellows had it as well.
So what is that personality?
Well, the most common are high conscious. So I looked at Myers-Briggs MBTI, which you may or may not be familiar with, and the big five. Yeah, the big five. So I looked at those two. And on the big five, it's high conscientiousness and low neuroticism are the two key ones. In fact, what was fascinating is your likelihood of being recommended by your patients and even your trainees is more related to low neuroticism than any other trait. So I think having that calm, non-anxious presence in theatre, very reassuring for trainees, but patients, and it also protects against burnout. And then the extroversion, introversion is interesting because the old way of training was very much a firm, it really favoured extroverts, whereas the new way of training, certainly in the UK, I don't know what it's like in the States, is much more tick box based, competencies, and that seems to favour perhaps more introverts. So we're seeing more introverted surgeons come on board.
Right. I always thought of failure is just part of the road to success. It didn't bother me. Like, forget ophthalmology for a minute. If I wanted to be better at tennis, well, if I failed and I lost a match, or I lost a game and a set and a match, I lost everything, that's okay, because now it made me better. I learned something from that experience, and it's on the same path or the road to my ultimate goal of being a better version of me when it comes to tennis. And I kind of apply the same thing for ophthalmology, for surgery.
I think it depends on where you're getting your value from. This is where it can go, very, very deep. But I guess, growing up, my acceptance was generally around being good at stuff, being successful. And so what I do is less of an issue now than it was, but who I am is what I do, a human doing, and so failure for me was, my first year as a consultant, I just was scared stiff of failure because I took it so personally.
We all do.
But then the danger is you take failure personally, and instead of stepping back from it, you then add to your technique, where you become more and more thorough, but you add more layers to your surgery to try and avoid failure. And I think operating to avoid failure is different to operating to achieve success, because you end up treating yourself. So I'll often sit there or with my fellows and go, why did you do that? Why did you put a gas in that last 2 months when an air bubble would have done? And there's something about 2 months which is reassuring. Maybe because in 2 months' time you'd have left the firm. You'll never know if you failed. But I don't know. We've got this Christmas gas over here which lasts 2 months, which is great for Christmas because at least you get Christmas off. But it's very easy to overtreat the patient, thinking, well, I'll be successful because I've done so much. But that patient can't see, for instance, with a gas bubble in the eye or fly. And so the patient pays the price, I think. And I think the hospital system pays the price for more interventions, more costs, more expense, more hospital visits. So for me, the biggest journey, and this book has, really helped me with that, is this journey of learning how to fail well. That we're all going to fail, but it can become really intense, where you're just desperately trying not to fail, and then you overtreat.
But I think we're all our toughest critics. I had a patient on Monday of this week, and I did cataract surgery, perfectly routine, very highly myopic patient, and I've done tens of thousands of cataracts. I take pride in my craft, obviously. The case went beautifully. I see on post-op day 1, pressure's up. A little bit of corneal swelling because the pressure's up. Pressure's like 40. Okay, so I thought, man, I'm really so careful about removing viscoelastic. What can I do? I went back and I watched the video. No, I swept the angle. I was very thorough in viscoelastic removal. Yeah. So let me just burp the incision and see her back the next day. Pressure's still up. Well, you know what? She's a steroid responder. But I still blame myself.
Yeah. I mean, it's great you can even just discuss this out loud, because I think there's a real issue, and I wonder whether our circuits of PowerPoint presentations on national stages means that there's a tendency to always present your best cases and your, a new technique that actually took you 3 hours to do, but you've edited it down and chosen your best version. So now you look really slick. And so everyone who tries it goes, well, I'm hopeless because it took me 3 hours. And I think I would really encourage an openness. I mean, the American system's much more private oriented, isn't it? And in the NHS, we're all in it together. So there's not a great advantage to appearing better than anyone else, actually. But I think some honesty to say, look, I screw up, I have complications, it's fine. Right. I was once at a conference where it was the closest I've got to standing up and grabbing the microphone. It was just hilarious. Every member of the panel presented complications from their fellows. And I felt like standing up and saying, my name is Stephen Lash, I'm a consultant, I have complications. Right. It's crazy, it's crazy.
Right.
So it's really good that you're able to just openly, after 10,000 cases, these things happen.
No, I did 10,000 many, many years ago. Well past that, tens of thousands. Fun. But here's the best point. I give lectures and I say, okay, who in the audience who does cataract surgery has never dropped a nucleus? Let's raise your hand. And then I tell everyone else, look around, those are the liars.
Yeah. You're not trying hard enough.
Right. Look, 100% of my complications I put up online on CataractCoach.
Yeah.
And I also people watch everything on YouTube, but I actually have a CataractCoach.com. Like I say every time, CataractCoach.com, right? On the website itself, under the complete list, I've been categorized. The category that says complete cataract cases is always me operating, no other guest surgeons.
Yeah.
And it's the entire case unedited.
Yeah, that's the important thing.
You can see it all on it. And I'll often say, like, I had a case recently where I said, okay, a very complicated case, and I show a 4 or 5 minute video, and I say, this case took me 38 minutes. These are the highlight clips. Or if I show a video at faster speed at 2x or 3x, I'll put a 2x on the screen so you can see that, okay, it's 2x.
Yeah. Yeah, I think it's really important to showcase in their entirety. But here's an interesting thought, because I've heard the term hindsight many times when people think about their cases. And I just want to say that your best way of analyzing your complications is not through hindsight, because hindsight really looks at the outcome in terms of what you did. So there's system 1 and system 2 thinking. So the easiest way of remembering this is just system 1 is driving your car. Okay, you can have the radio on, you can listen to the story tape, you can chat to your friend. System 1, your brain is just in low mode, hardly any of it's lighting up. It's easy. Have a conversation. Car pulls out on you. Suddenly, you can't listen to the story. Your conversation stops. All of your brain lights up. You're in system 2. And when we're learning as surgeons, we're in system 2, which is why I don't tend to chat much to my fellows during surgery, because their brain is completely taken up with what they're doing. Do it later. So when you have a complication, rather than look at the outcome, I would look at your decision making during the case and use system 2. So when the case is over, stop and reflect on that case in detail, in great detail. In fact, I'll often, if I've got a fellow who's learning scleral fixation at the moment, and he had one case in the morning and one case in the afternoon, both with scleral fixation, because he can isolate those 2 cases now and go home. He will go home. He's very good, and think about it and think about the micro technique. And so, don't beat yourself up with hindsight. Use system 2 thinking and analyze your case.
Yeah, like I think the important thing too as well is reviewing that game day footage. I could always tell when I taught residents. I taught about 200 residents over the course of more than 20 years. The ones who came to the operating room with a USB drive, put it in the scope and said, I want to record this case. Then I think, okay, you actually care about your future. But I did definitely have residents. I said, oh, you didn't bring a thumb drive? No, I don't need to record this one. Like, are you out of your mind? You've done like 40 cataracts. I've done like 30, 40,000. I still record every case I do.
Yeah.
Just so I can learn from it. And listen, I may record over that case.
Yeah, absolutely.
But I won't save all the videos, but I do just in case something happens, I can learn from it. And even the best professional athletes, you name the sport, they all watch their video footage.
Yeah, it's interesting that in the England rugby team, the best players were the ones most engaged with the coaches. We have this sort of sense that I don't know quite what it is. I don't know whether it's pride or ego or maybe even lack of confidence to be criticised. But it's quite hard to take criticism at any stage of your career. But I would say as a trainee, that's the time to actually invite it. Just say, please tell me, if I'm doing anything wrong. And as a consultant, it gets tricky. And I have to say to fellows, look, if you see me doing something stupid, let me know. I mean, the airline pilots do that all the time with their first options. There's so I think inviting, there's this great proverb, faithful are the wounds of a friend, but deceitful are the kisses of an enemy. And I think the wounds from a friend can be great. And we just need to learn to embrace criticism. I find it really difficult. My wife will tell you my worst trait is defensiveness. Because I think I'm trying hard all the time. And
we all get defensive.
And then you say, and I did this wrong. I did all this. I left my socks at the bottom of the bed. So it's very, it's important, I think, to invite criticism. And the other thing about, in terms of reviewing your surgery, is what I argue in the book is to go to this micro level of audit. So for instance, I sat down with one of my fellows at a conference somewhere, and he said, can I just chat to you about my cataract surgery? I said, okay, well, let's go through a case. Well, it took us an hour to go through the case. And he started saying, so I said, how do you start? He said, I just make a corneal wound. And I've got another friend who hates the term wound, corneal incision. I said, you don't just do anything in surgery. What does the perfect corneal incision look like? In micro detail, do it, and then score yourself at that moment out of 10 and go, was that perfection? And then do the next stage. What does perfect look like in this? What does a perfect rexus look like? What does a perfect, and you split your surgery into these tiny, tiny components. And then as you're operating, you're constantly auditing how you're doing. Now, the thing about that is you'll never do a perfect case, but you start to think about it in detail.
Oh, that's so brilliant.
And just break it right down.
Oh, it's absolutely brilliant. So I do the same thing now. Every case I do the capsular rexus. My goal is to have not only a perfect rexus, 5 to 5.5 millimeters, briefly centered, but I want to make it so perfect that you cannot tell where I started it or stopped it or finished it.
Okay.
It just perfectly good. You don't see that little bit of a widow's peak. No, not for me. I want it like, and it makes zero difference. It makes zero difference in the refractive outcome.
Yeah.
To me, my signature is my incision and my rexus, because even 20 years later, someone look at the eye, see your incision, and they'll see the rexus, and I want those to be absolutely perfect.
Yeah. And I don't, so again, I argue especially the musician section, when you see a virtuoso in music, they are way, way better than even very, very good musicians. And I just think we're audited on standards which are plus or minus 2 standard deviations, which is like 90% of all surgeons. So our standards are mediocre. We compare at mediocre. Where's the drive to perfection, to virtuosity? And I'm not saying I'm a virtuoso, but you have more of a chance of getting better if you break things down into small bits. And then you get marginal gains in each of those bits. So for me, the Rex is exactly the same as you. So I can grade most of it initially, but the last bit only when the lens goes in, because I want to see the Rex is just inside the optic. But I do it in maximum. So I use a needle for my Rexus, and I just use the needle. I don't swap around. So lean is minimal movement. And my gold standard now is 6 sweeps. So I've seen people do Rexus where they go out and they nudge, and it's like 100 movements inside the eye to do the Rexus. I had one fellow actually who did that for 90 degrees. Then he got his Utratus, did a beautiful, and I said, why don't you just create the flap and then use the Utratus, or even better, use the Utratus?
Like I do, just the forceps.
Because you want to cut out unnecessary. So one of the wastes is waste of movement or motion in mudda. Mudda means waste in lean processing. And it's quite right. The more movement you have in the eye, the more likely you are to have inadvertent damage, the longer things are going to take. So my perfect Rexus is, in the middle, it's centered, it's just inside the optic, and it's 6 sweeps. Do I do that often? No, not very often. Sometimes it's 8, sometimes it's 10. And some Rexus have a mind of their own. They just want to go out. Some are very flimsy.
You know what's funny is I don't even care how many times I have to regrab it, but I want the final outcome to be Perfect. I changed my mindset a lot. So if you look carefully on YouTube, there's a video of me operating about 20 years ago when YouTube first came out.
I was going to say that's
Standard definition video. And I was so naive at the time. I was so stupid that I thought it was so slick that I did a cataract in like 3 minutes and 3.5 minutes or something. And I was just like, oh my God, what a fool I used to be. So it's funny, on CataractCoach, maybe I'll put a link down below. I reviewed that video of me. I reviewed myself like 15 years later saying, look at this fool. He thinks that speed, it means nothing. And there, I used to think, grab the capsule 3 times, like a Mercedes sign, 120 degrees, 120 degrees, 120 degrees, I'm done. But today, I operate every eye as if it's my eye. And if it's my eye, I don't mind if it's 3 minutes, 5 minutes, 7 minutes.
Yeah.
But I want that thing to be beautiful.
Yeah.
And so I had a very different change in mindset.
Yeah. And speed is, I don't know, there's something about speed, isn't there, that boosts your ego, and you see these people do.
But imagine every ophthalmologist I've ever met in my entire life is crazy.
Yeah.
But just different extents and different flavors of crazy. But we're all crazy.
But imagine you went to a violinist virtuoso competition, and the winner did it the fastest. I mean, it'd just be ridiculous. Just be ridiculous. So one of the first things I get my fellows to do is I get them to do an audit of their surgery. And so I say, right, video your surgery, and I want you to break it down into every section. So we start at time 0, right? When's the main incision done?
Mm-hmm.
When is nothing happening? When is the side port done? When is nothing happening? The rexis, every single bit, time and motion. And I say to them, the first thing I want you to do is to go over that and spot all the times when nothing is happening and work out why nothing is happening. You know, if you're adjusting the music or changing the playlist or, whatever, make sure everything's set up before you start. So first of all, get rid of doing nothing, and then look at every single section and do what I said. What is perfection?
Optimizing every step.
Find someone who's perfect at what they do and then copy them, and then do that again. And then the final thing is to go back over and go, right, okay, so how can I do this even better? So you're just constantly auditing. But the first thing is just to stop doing nothing, because you see, the guys who are just starting off, and there's huge gaps. So speed is not the purpose. It's not the goal. It's a reflection of efficiency, exactly, and not doing things. So I mean, I've got a little bugbear about. This is where you tell me this is how you do it. But you make an incision, and then the keratome goes back to the scrub nurse, and then the helong comes across. That goes in, then that goes back, and then the blade another blade, maybe a 15 degree. The side port's made, and then that goes back. And I say to the trainee, so why have you done that? And they'll inevitably use a heuristic, something called the representative heuristic.
Mm-hmm.
And all the heuristics in surgery their soil tends to be in failure and disaster. It's like, you always remember the bad comments, you never remember the good. So it starts. So they go, well, once I made an incision and the AC collapsed. And so now what I do is I make the incision, then I make sure the AC is stable. And then I make it with a 15 degree blade. And then, but that blade is going backwards and forwards. So that's a risk and a danger. And I've certainly seen surgeons and scrub nurses stabbed with a blade, because it's, why not get the keratome, make the incision, make the other incision, take it back, then the probis. So if the AC collapses, what that tells me is you haven't done the incision correctly. The AC shouldn't collapse. But if you apply that principle to every step, so you make an error, you remember it, you do something additional to stop that happening again, slowly your technique just gets bigger and bigger and bigger.
Yeah.
So you need paint stripper on it and just go right back to what does perfect look like? Stop doing nothing. And the other beauty of splitting your surgery up is a lot of the sports psychology techniques can come into play. So one of the most powerful, which is phenomenal, is called imagery. So athletes use this, they've used it in rehabilitation, musicians use it. So imagery is where you think in great detail about your surgery, and it has to be in great detail. So I used to do this on the train to Bournemouth, where I was a trainee. It's about a 45-minute train ride, and I would just go into this world, and I'd only just started ophthalmology, where I would play a cataract through in my head, and I'd bust the capsule. And then I'd think about what I'm going to do. And my heart was racing. You have to be really in it. You have to imagine the smell, the heartbeat, the everything. You can't just casually think about it. Now, if you do imagery on something you've done in the real world, so you can't imagine what you haven't done, you will lay down connections in your brain the same as physical practice. It's quite phenomenal. It's phenomenal.
Well,
so we can practice, but you have to deep dive on it. And so the advantage of, so this is where lean is synergistic to, you know, the sports psychology techniques. By breaking it down to these small sections, you can mentally rehearse them at different points during the day. And the other thing is, a lot of sportsmen have performance routines. So they have something that they do just before they do whatever they're going to do. And then you can have these little routines that prepare you for the next step. So I think imagery is absolutely fantastic. But it also explains why, I'm sure you've had this if you've done a million cataracts, but when you go off piste and you think, so for instance, once I had an AC lens that was spinning. And I thought, well, in my mind, I think, well, I'll just suture the haptics to the iris. That'll be fine.
No,
never done it. But so you go in and you realize that the straight needle is like one of those child snakes, you know, with all the little beak, and you move the tail one way and the head goes another way. So that was a disaster. And then AC collapses, and then I could get one in, but I couldn't get the other one in. So this concept of no plan survives first contact with the enemy is that when you try something that you haven't done before, you can't imagine it. You just can't imagine all of the things that could go wrong.
Sure.
So imagery only really works with stuff you've actually done.
You've experienced before, for sure.
Yeah. So I don't know whether have you ever thought of that or done? You must have thought about cataract surgery in your head before.
Oh, I'm completely crazy. Listen, I'm so crazy that I decided to make a video source that has a new video every day about cataract surgery for 2,600 days in a row. I've never missed a day. That's a very fine line between madness and passion. There's a very thin line there. Yeah. So I love it, but I will almost always, like, my big operating room day or theater day for you is Mondays. So Sunday nights, I go to bed early. I lie in bed. I think about the tough cases I have the next day.
Yeah.
And I will play them through my head. And at the point where, like, okay, what will I do if I find terrible sinus report? I'll go this way.
Yeah.
What will I do if I find out that the posterior capsule has been violated by that prior individual injection? I'll do that. So I will, like, I'll go to bed literally just playing these in my head. And sometimes I'm so into it, I have to, like, oh my God, it's been like an hour I've been thinking about this. I need to just shut off and go to bed.
Yeah. I think that's a really positive trait. I like to hear that in my fellows, where they just get into their own heads and they think about these things through and through, you know, in immense detail. But the other interesting thing is you get more expert. So for instance, speed cubers, you've probably seen a speed cuber do it without looking. And you think, how can you possibly do it without looking? But what they're doing, and this comes down to a section in chapter 3 on complex problem solving and schema theory.
Mm-hmm.
So what an expert will be able to do is so an expert chess player will have multiple chunks of moves going out much further than an average player, and they can pattern recognize and then execute. So a speed cuber will look at the cube and they'll recognize the pattern, and then it's automatic.
Right.
And so you can solve quite complex problems in system 1. Now the advantage of system 1, and that, you know, when you're operating and you're in sort of tick over mode, is that you have the bandwidth to now look around the case. Mm-hmm. So you can spot that, oh, hang on a sec, the AC is a bit shallow, or there's a bit of positive pressure, or there's, because if you get tunnel vision and look at one thing, often other things are coming in around, which is why training, you know, you just need to isolate each thing. Because you can go off, you're sitting there watching going, I can see what's going to happen here. The rectum is going out.
You know what's going to happen next. You know it.
Yeah. So but you can only build that up over many, many years. So schema theory, and I'll do this when I do a complex detachment, is I'll just do it. And then I'll chat with the fellow afterwards, and the unraveling that you have to do to say, well, I did this because these things can happen. And I thought in this situation, like you're doing beforehand, you know, and you just get better at that. And there's no shortcut to that. You just have to keep going with it.
No, you absolutely have to you've got to keep advancing your skills. You've got to keep being your own toughest critic, because we've all seen those few ophthalmologists in the community who stopped learning after residency and fellowship. And they operate today the same way they did 20 years ago. And it is glaringly obvious. In Los Angeles today, I can name a surgeon, who I will not, who still only does manual extracapsular cataract surgery, never learned phaco, said, I just do my own way. Blows my mind.
I think it was about 10 years ago. We had everyone's trying to fix the NHS all the time, by the way.
Okay.
So we had a big management guru come in on television. It makes good television to fix the NHS.
Yeah.
And they discovered someone doing GA extra caps.
Okay.
On a list. Now we can criticize, but if we're not careful, we can become that person.
Right.
And what I love about trainees is they're always bringing new stuff in. You know, there's
Right.
always, I learn as much from my trainees
Of
as
course.
they do from me. And so it's wonderful to make sure you're keeping up to date and just challenging yourself all the time.
Well, that's the beauty in Cataract Coach, is that this will always be cutting edge. It's always the newest stuff. I get 50 to 60 videos sent to me a week. I watch all of them. I choose the best ones. I edit them, do the voiceover, put them up for the world to learn, and we all learn together. But yeah, we keep advancing our skills. I learn so much every year just by making the videos.
Yeah, it's amazing. I'm amazed you're still that enthusiastic after that many years. And I mean, how do you fit your life in around this then?
Well, like I said, there's a fine line between madness and genius. A very fine line. So, you know, I'm like you. This is what I love. This is my passion. There is some sacrifice involved. I mean, how long will it take you to make one edited video? It's a couple hours to edit a video, do a voiceover, put a title slide, render it, upload it, optimize it, write a description. It takes time.
But personality-wise, have you studied Myers-Briggs and the Big Five?
Yeah, for sure.
So how do you figure on those if you're prepared to say you may not be? I'll disclose I'm an ENTJ on Myers-Briggs, which is the field marshal.
So I don't remember all the little specific things and the number letter of this, but I mean, I have always been exceedingly hardworking.
Yeah.
And so for me, it's just like, if it's hard work, I don't mind. I will never lose. Whatever.
So what drives you? What drives you to work so hard?
Wow, that's more complicated. That's a complicated thing. I think a lot of it has to do with a bit of a tumultuous and crazy childhood. And so I've got to prove to myself that I'm actually that I'm worth it.
Yeah.
So like I had the personality where in school growing up, if I won second place, I would throw the trophy in the trash can, never bring it home. The first day of high school, I went to the admin office and figured out, okay, can I ask, what's the criteria for a valedictorian? So that 4 years later, when I graduated, I was number 1 out of 750 because I knew the rules ahead of time of how they will choose. And it was super important to me to no matter how hard it is, I have to achieve that. So I don't know, I have that kind of crazy drive that I just can't stop. And now that I have 2,600 videos in a row, I can't jump off the train now. I can't break the link now.
Yeah. But it's interesting.
Go ahead.
But you're very driven and you need success, and yet you're quite happy to share your failures here, and they don't affect you personally. So you're either so that's interesting. You got that.
You know what success is? Success is failure plus one more.
Yeah.
That's something it is.
So you're likely to be very, very high on conscientiousness, clearly. What about neuroticism? So negative emotion, anxiety. What are you fairly calm? What happens when you get a complication? What happens to your heart rate? What happens to you?
So I have a video on this on Cataract Coach. So I wore a heart, those chest straps, the heart monitor from exercising, and I did surgery on the mother and father of a fellow ophthalmologist in LA while he sat in the room and watched.
Right. Okay. Yeah.
And I have the video on Cataract Coach, and my heart rate didn't get above 80.
Yeah.
And his dad was like small pupil, pseudoexfoliation, dense cataract, no problem.
Yeah.
And in fact, I did surgery today, this last Monday, on my 84th ophthalmologist. I keep track of how many ophthalmologists I've operated on, and I give them for every ophthalmologist I do surgery on, I do obviously the best job I can. And I give them all a USB drive. Here's a video of your surgery because I know you want to watch it.
Yeah, that's fantastic. Yeah.
So, and for even for those, heart rate cool as a cucumber. Doesn't go. Doesn't please me. And even I've been used to teaching residents. I have always done two things in parallel, kind of like you do. I did my residence at UCLA. I was professor at UCLA. I taught residents at a big kind of charity or county teaching hospital.
Yeah.
It's maybe like an NHS trust hospital for 22 years. And I also did my private practice. So when I was teaching the residents, the capsule breaking rate among residents is about 6%. So I can deal with anything. And so I would always sit at the head of the bed. Residents are operating temporally, usually for cataract surgery. No matter what happens, I will rescue the case.
Yeah.
So I can just stay cool as a cucumber. And so it doesn't bother me.
I think that gets easier as you get more experienced as well. And that's been shown that more experienced surgeons have, we have more tricks of the trade. But how would you advise trainees who are having a complication are there techniques you could say to them, can you control this? How do you train them to have complications? Because one thing I'm concerned about, and we did a little study in the UK on this with trainees, is that society's appetite for risk has gone down and down. Our playgrounds now have foam so that nobody gets hurt. Children aren't allowed out to play. There's a safetyism in our culture, and it's bled into the NHS. Goodness knows how we get heart surgery off the ground these days, dangerous things like this. So our trainees are coming to us with this aversion to failure and safety, and patients don't tolerate it. And yet what we're finding is we have a high percentage, 80% of our trainees don't feel confident managing posterior capsular rupture because they've never had one. I've got a trainee at the moment that I'm just saying to her all the time, if you bust the capsule yet, do some harder cases.
Yeah.
Because she hasn't bust one. She's had people take over and she's completed cases, but she hasn't. Now, I'm not advocating that people bust capsules, but you're going to bust a capsule. Right. And so it's worth, I felt like I transitioned from technician to surgeon when I started busting capsules, and I had to think on my feet. So have you got any techniques? How do you help your trainees fail?
For sure. So first, accept that it's a known thing. You're going to have a complication. There are 0 surgeons on the planet, 0 cataract surgeons who don't break capsule. There's 0 cataract surgeons who don't drop the nucleus. That doesn't happen. It's going to happen to you. I was just in the UK. I was actually in England last week. I was speaking at Millen Pandy's Royal College of Ophthalmologists meeting, a state-of-the-art refractive and cataract surgery meeting in Hull. And I heard one of my friends, a Turkish surgeon, Başak Bosansi, and she talked about one great pearl that I love. And that pearl was, when you have a complication, take a step back and now pretend you're fixing a complication that was referred to you. And I thought, what a genius move, because very often in Los Angeles, other surgeons will have a complication, and they'll send me the case to fix it. And I won't be nervous at all because I'm just helping. So she says, stop, take a breath back, and pretend like, okay, now this case was referred to you. Now it's your job to fix it. I thought that was brilliant.
Absolutely, yeah. I use the Sun Tzu Art of War, when you arrive on enemy land, burn your boats. So there's a sense in which,
for sure.
When you have a complication, you've got to fix this now. There's no going back. And there's a confidence that comes from, because part of you want to run a mile, you just want to get out of there. So there's a way of calming yourself down, saying, I've just got to carry on. Now, of course, this needs to be appropriate for stage of training. If it's your first cataract, you may need to stop and let someone else take over. But you do need to push in to complicated situations and learn to remain calm. And that's why I think imagery helps, because any resident, I think we're starting to call our junior doctors residents now. So they're
not registrars anymore?
No, residents. I think that's the new buzzword. We just copy everything from America. We've got sun as well here at the moment, which is pretty amazing. Imagine that your boats have been burnt. Press on going forward. Imagine. If you've only done 5-10 cases, you've done enough cataract surgery to imagine, and then start to imagine what you do. Think about fluidics. Think about turbulence, flow. Think about when you've got a vitrector in the eye, where's the fluid going? You want it all going backwards. You don't want to be fishing in the anterior chamber, so fluid goes back and hydrates the gel. Just little things like that, and just think about it and do it time and time again in your head. And then when you actually have the complication, part of you will feel familiar.
Right. I think an important thing too is that if you're a young surgeon in training, whether you're a resident or a registrar or a fellow, whatever you are, if the onus is on you, it's on your shoulders to make a list. Here are the things I need to learn during this next year or two. I need to learn how to do a good anterior vitrectomy. I need to learn how to put a sulcus lens on the optic capture. I want to learn how to do Yamane, intrascleral habit fixation. I want to do a pupil plat. Make your list, and the onus is on you to first prepare ahead of time by studying it, watching videos online, and then come to the operating room with a game plan so that your consultant or your professor or your attending can teach you, like, okay, let's go through this. Yeah. But you've got to, I think the biggest challenge we had, and don't learn this from America, by the way, I don't want the generation of spoon-fed kids.
Yeah.
You need to go out there and earn it on your own, and you need to be proactive about this. Do not come to my operating room with saying what's the Greek word? Tabula rasa, blank slate, Latin word. With a blank slate in your head saying, okay, I'm here, teach on me, go ahead. No. Yeah. You prepare ahead of time, put in the effort, and you tell me I will help you, but this has got to be self-led, because the rest of your career, you have to teach yourself. I didn't learn DMEC in residency or fellowship. I learned it on my own 5 years ago by watching videos.
And I think that's where this internal, external locus control comes in. I think maybe even increasingly as a culture, we're an external locus control culture, that it's always something external to me that's the problem.
Right.
Whereas good surgeons, internal locus control. Why did this case go wrong? Because I did something wrong. Not that the patient moved, not that this happened. So having a high internal locus control, and we're born with, you know, a bias towards one or the other. Lower socioeconomic families tend to raise kids with a high external locus of control.
Right.
When you look at businesses, the CEOs and top managers have a high internal locus of control. So it's something you can challenge. So, and failure, as we've had this conversation already, but failure is so difficult to take sometimes. It's easier for your ego to push it externally. And I'll be tempted to push it externally, and I immediately bring it internally and go, no. If it's all external, I can't do anything about it. I'll never get better. So high internal locus control. And I think what you're talking about there is high conscientiousness, which is a trait of good surgeons.
Right.
And I'm very lucky, because in VR is very competitive in the UK. So pretty much every fellow I get is, you know, mad keen and wants to get better. But I don't know what it's like in the US for volume, but there's a real attack on volume. We're shortening our training. We're reducing exposure. We are, selecting, less and less more complex cases for the trainees. They don't get to the table very much. I mean, how many cases are your fellows and trainees doing?
So it varies. So if you look at these cataract numbers, the minimum for the 4 years of residency for what's called the ACGME, American College of Graduate Medical Education, is 86 cataracts in 4 years. Wow. As a primary surgeon.
So it really is private practice then? You get to practice in private.
I'll tell you, that's the minimum. So among my residents at UCLA, when I taught there, and I taught there for 22 years, from the year 2000 to 22. And during those years, I'd say an average resident is about 230, 240 cataracts.
Yeah, okay.
A lower end of the bell curve resident is 180 cataracts. A hardworking resident is about 300 cataracts, maybe more, 350 even.
Yeah.
But here's the catch. I'm old-fashioned. I believe in equal opportunity, but I do not believe in equal outcome.
Yeah, absolutely.
So every senior resident, the same amount of OR time. You get exactly this many 8-hour days, same as every other senior resident. If you're very efficient, you may do 10 or 12 cataracts in that 8 hours. If you're not, you may do 5 or 6. But if you're a slow surgeon, and especially because oftentimes it's because you failed to go to the wet lab and do the required training, you just didn't do it. You don't care.
Yeah.
And then I will not give you twice as many OR days as the other person to make up for your deficiencies. No, it's equal opportunity only. But the big problem is, especially in the US, there was a big shift the last 5-8 years for nonsense, throwing merit out the window. The university where I'm retired from, UCLA, has been in the news recently for a news article, which, in fact, I may have to even show you the title, because you sometimes can't even believe it. You can't believe this is actually true. It is Literally, that's the title. The title says there, federal lawsuit
Yeah.
against UCLA Medical School. They used nonsense criteria in rejecting highly qualified students over less qualified students. They use social criteria. You've got to be crazy. Like when I fly on a plane next week to Asia.
Yeah, the pilot.
All I care that the pilot is top 1% for skill. The rest, I don't mind. Whatever you are, I don't care.
Yeah. So I think the common theme here is have a high internal locus control, be conscientious.
Right.
And you're not going to get, the thing about volume is that it'll go up exponentially. As you get better and more confident, you get quicker. But I try to say to my trainees, you've got to squeeze everything out of the case, both in prep, during and after. So it's debriefing yourself in system 2 immediately after the case. I'd also recommend prospective audit, so that you audit as you go along with outcomes, because then you have some memory of the case, but beware of there are other heuristics I talk about in the book. So one is the law of small numbers. So be wary of your small numbers of making any big decisions, because you may have 0 PCR. You're not the best surgeon in the world. You may have 6. You're not the worst surgeon in the world. You need big data to make those decisions, but you've got to squeeze everything out. And then once a year, review all your cases and go, okay, what can I make subtle changes in here? What you don't want is a technique that changes every time you come to the table. So there's this balance between perfecting, what does perfect look like, and then revisiting, coming back time and time again. But I think you're right about the videoing. I think that's an absolutely essential skill. You can do it in your head afterwards if you have time. But if you've got 6 cases on the list, you're not going to have time to debrief each of those cases in your head.
Yeah, no, you have to record it. You have to watch your own video, because sometimes you do things you don't realize. As you were saying earlier, when you're a younger surgeon or less experienced surgeon, you tend to focus, let's say, like just on the phaco tip, not realizing what else is happening outside that one specific zone.
Yeah.
Like
one of my first phacos, I was had the phaco in the eye, and the chopper in the left hand, or a manipulator, and the left hand just drifted out the eye, completely out the eye. I hadn't realized that it was because you forget that you're so focused on the tip of that phaco probe.
Right. Yeah, a good example is so focused on the tip of the phaco needle that you don't realize you're not floating in the incision. You're shoving the needle and the phaco sleeve up against the side of the cornea, the edge of the incision, and you cause a phaco wound burn.
Yeah.
And we've seen that. I have videos on CataractCoach of this. Like, well, that's a young surgeon, but that's okay. The difference between a mistake and a lesson is you learn from the lesson.
Yeah.
So if and it's what you said earlier. In fact, it's funny you said that. One of my sayings for residents was, the purpose of your residency is not the certificate that you're going to hang on your wall. Your purpose is, for these next years, can you squeeze every drop of experience, hands-on learning out of the training program? That's your goal, not the certificate.
Yeah. And also, as we've said, as you then go on through your career, remain enthusiastic about it, remain curious, remain reflective. And as I say, this chap I went through his cataract with, don't ever say, I just do anything. You never just do anything. There's always, and I think it's important, to sit with different trainers as well, because you'll see, our personalities are very different. So, for instance, I thought of this sort of I did an MBA, so everything is a 2x2 grid now. But if you imagine that the eye is sort of on your side, so it wants to heal. It's sort of on your, so sort of philosophical or against you. Or if you have a technique that is very lean, you do minimal amounts of surgery, or you have a technique which is really belt and braces.
Okay.
So you hear people say, if it's going to go wrong, it will go wrong. So they believe the eye is not on their side. That gives you 4 quadrants, and that produces 4 very different surgeons. So one will think everything's going to go wrong. They do everything they can. Their cases may take a long time. I guess they feel like they're being very, very safe and thorough. But the reason we shouldn't be treating relatives, perhaps, is because when the risk goes up and the fear of failure goes up, you may overtreat. So I talk about walking the well-trodden path. Don't take shortcuts. Don't take long cuts. Do what you do every time. Doesn't matter whether it's the King of England, or you should do your surgery the same way, because it's when you veer off into long cuts, being safe, or shortcuts, being sloppy, you're going to come a cropper. So stay on that path. And it's worth thinking about how you see the eye. Is the eye, it's an amazing bit of kit, isn't it, the eye? I mean, it's incredible how even a case that goes badly doesn't necessarily end badly. And likewise, a case that goes well doesn't necessarily end well. So the other thing about a complication is to stop and go, this isn't the end of the game. You know, I guess unless you have an expulsive hemorrhage, maybe. But, you know, just because they've had a posterior capsular rupture doesn't mean they're not going to do well. So don't throw it all out. Just stay calm and keep going. But it's worth thinking about this, you know, these reasons. I think the other thing about surgery is I'm a bit of a purist in that if you pursue surgery for surgery's sake, other stuff that you may be interested may come your way as well. You may be on a stage, but if you do the surgery for the stage, it's a secondary reason you're doing the surgery. You may become wealthy, but if you do it for wealth, then you may change the way you operate in order to maximize that. So I guess I'm a bit of a purist, and I just want to do it really well. And the satisfaction from doing something really well is great. It's just, unfortunately, with people who are high conscientiousness, we're very harsh critics of ourselves. So we need to learn maybe to give ourselves a bit of slack sometimes as well, and just say it's not going to be perfect every time.
That's one of the hard things. I find that, you know, I'm certainly my own toughest critic.
Yeah.
And maybe I'm too hard. Maybe I'm too hard on myself. Maybe I should give like, again, I'm blaming myself for this patient having steroid response IOP rise after surgery. I'm like, what could I have done differently? Well, probably nothing, to be honest. Maybe don't give her steroids, but how did I know? I couldn't tell ahead of time. I don't know.
Yeah. Yeah, it's very, I mean, I think sometimes I've videoed cases where I had a posterior capsular rupture and I just can't see when it happens. And that's frustrating when you can't see why, whereas other times, so there was a case where I was doing a sclerotic fixation. So we had to modify the Yamane technique. And again, so micro technique, okay, so I thought, well, he uses a fellow showed me, I watched the video, I imaged it in my mind, I went through it time and time again. I looked at micro technique, how's he holding the needle, how's it bent? Did the first case, completely fluke, got away with it, did it in about 30 minutes. 4 fellows came to watch, they thought it was amazing, and they left. Second case was another Yamane. After 2.5 hours, I gave up. I'm glad they didn't see it. They thought, because little things of the micro technique weren't working. The bevel was pointing away from the curve of the needle. It wasn't a 30 gauge needle, it was a dermal 30 gauge needle, which has a much higher internal bore. It was probably a PVDF haptic that Yamane had with the Zeiss Lucia. We were using PMMA, which are very unforgiving. They can
fracture, yeah.
So I've done all mine on PMMA, and the micro technique for that, and the way I double bend needles to stop the kinking. And so my fellow today did 2 cases. He said to me, he said, rather than micro technique, it's nano technique.
Right.
It is just, and you can't, so the trouble is you can't imagine it. You can't practice it until you've done it. So with all surgery, you know, and I think, you know, what you're doing is absolutely fantastic. There are certain techniques, until you actually do them, there's a gap between what you see. It's like a magician who pulls a bunch of flowers out their arm, you know. It's like, well, how did you do that? And so you have to do it in order to even begin to do it. So doing it is the first stage, then reflecting and repeating and repeating and refining and refining. And it's micro technique or nano technique is where the gold is. You know, you can't just look and copy, you have to break it right down. So don't be frustrated if you watch things, then you try them and they don't work. You've got to look at the micro technique.
Right. It's like, I'll show a video on CataractCoach. Just stick with the Yamane technique. So I basically met Shin Yamane, and he says, Uday, it's not Yamani, it's Yamane.
Yamane.
So in that technique, when I show you a video on CataractCoach, it's probably a surgeon who's doing it, who's done this a couple of 100 times. So when you do it for your very first time, you watch the video, like you said, watching a magic trick. Now you're going to try the magic trick. It takes a little bit of time for your hands to be able to do the sleight of hand and the beautiful magic. It's okay. Stick with it. Don't give up.
And I think this is another thing that frustrates me with learning curves. So I discuss learning curves, whatever they are. I mean, they started in psychology and learning figures and numbers, and then they moved to airplane manufacturing became the experience curve, and they moved into medicine in the 80s. And it's, when you really think about a learning curve, it's entirely complex. I mean, for a start, what is on that y-axis? Is it time? Because your time will get shorter the more experienced you get, and your variability of time for complex cases will compress. So a good surgeon, as they get better, will get quicker, but they'll also get more consistent. But is it, or are you just rushing and getting faster? And then, and a steep learning curve is a very easy to learn task because you're making rapid progress over a very short period of time. But the learning curves can go backwards as well when they did the initial research in the late 19th century, I think it was. But I think we love the views from the foothills of the learning curves. We do 15 cases and then we think, well, we've done that. Let's move on to something else. I think I've done maybe 500, 600 Yamanes, and I'm still discovering complications, even at this late stage. There are very few now. I've been through most of them, and the beauty of training the fellows is I've been here and I've done this. I mean, the one today had a Malugan ring. And I said, well, twice at about 250 cases, I managed to thread the haptic through the Malugan ring. That's a disaster. And then once I actually was taking the Malugan ring out and the muscle memory just flipped it and it pushed the lens out. So I've done all these, I've made loads of errors, but the beauty is you learn from them, you teach them. But what is a learning curve? And some of us are going to have heights of competency in excess of others. We all like to think we're above average, but we can't all be above average. But persevere. I think the views from the peaks are much better. They just take a lot of time and effort. And it frustrates me that we have, do 10, I can do this now, move on to the next thing. A virtuoso violinist doesn't do that. They spend 4 hours a day, 8 hours a day for 20 years. Well,
that's one of the danger things. When you teach, as you know, a young registrar, fellow, resident, they'll do about 100, 200 cataracts and think, oh, okay, I'm great now. I've done everything.
Yeah. There's the Dunning-Kruger effect. Have you heard of the Dunning-Kruger effect?
Of course.
The more you know, the less confident you are, and the less you know, the more confident. That's really important, that effect, though.
Right. So now it's like after tens of thousands of cases over 25 years, I can just see how much I don't know.
Yes. Yeah, absolutely. And another thing from culture, I think, which isn't helping us as surgeons, is the immediacy of everything. You don't know something, you Google it. You're bored. You could just get everything immediately. And there's something about, firstly, opening up time away from screens to think and to image and to reflect, but also that every task in life isn't achievable in a nanosecond, that things take a long time, and maybe just giving a bit of patience to this process, I think is really important as well.
Right. Especially now we've seen in retrospect, I know, like, wow, it's after 1,000 cases, after 500 cases, maybe I was halfway up the learning curve. After 1,000 cases for cataract, maybe I was at 75%.
Yeah.
And then now after, let's say if you had 10,000 cases, maybe you're at 98%.
Yeah, you'll never get there completely.
It takes many years to learn, but a lifetime to master. And I think we got to keep up with the learning throughout that. Now, if we were going to give a summary here, because I can't believe we've been chit-chatting for an hour already. That's what's funny.
It's 11 o'clock at night. Late night for me. Do you know if a surgeon has less than 6 hours sleep, their complication rates go up hundreds of percent. You may as well turn up drunk.
Whoa, I did. Well, thank goodness I sleep early on my surgery night, so I don't keep you up too much. But what would you end with? What are, like, obviously, I think it would behoove every person who's listening to this. If you're a surgeon and you're enjoying this podcast, the link down below, definitely check out this book. I promise you're going to learn a lot from it. It'll make you a better surgeon. But leave us with a couple of great pearls for younger ophthalmologists, say in their 30s, maybe their 40s. How can they become better?
Be conscientious and enthusiastic is the number one thing. Be really enthusiastic. Passion means sacrifice. It doesn't mean I'm really, really enjoying this or I'm really enthusiastic about it. It means sacrifice. It means to give something up. And what I'd encourage people to do is just to 3-box their surgery. In the box, I call it how, what, and why. I think I prefer, because once you've written a book and you talk to people, your thoughts develop. Think about execution. What's happening in the moment? How can you improve that? Think about intention. Why did you plan the way you did it? And then think about motivation. What influenced your thoughts to make the plans to execute? So just think about your surgery in those three boxes, those three perspectives. And if you do that, you'll get multiple targets that you can then try and improve on, and improve by marginal gains. But by far the most important thing is enthusiasm and joy and passion. You know, Chick sent me highly talk about flow. You've probably heard of flow state. I think probably what's as good as that is play state. I think that I'm playing. And when you play, you are in this wonderful space where you're calm. Time is whatever, and you're just playing. So just enjoy your surgery.
That's probably the most important thing. And I can tell you, if you're a young surgeon, going my third decade here of ophthalmology, 25 plus years, I still love it every week.
Great.
If I travel and I miss doing surgery that week, I feel it. I think, gosh, you know, this is a beautiful scenery. We're at some tropical island, but
let's do a phaco. Yeah. Absolutely.
And I think that's a good thing.
It is great. Enjoy it.
Well, Stephen, thank you again. What a fantastic conversation. I've learned so much.
It's been great chatting to you. I love your enthusiasm and passion as well, by the way. So thank you for your contribution. My fellows told me about you. So I'm a bit old and, you know, not with it anymore, but they put me on to you. So thank you. You've been a great help to my fellows for sure.
My pleasure. You also have to check out, we have a retina channel now, retinarounds.com, with a new retina video every single day.
Yeah.
So, and we certainly welcome any submission from you or your fellows.
Okay.
Either to Cataract Coach or to Retina Rounds or to both. We'll happily feature you.
Yeah, great. It's been an absolute pleasure. Thank you so much.
And remember, our listeners and viewers, we've got a link down below for the book. I promise you're going to love it. It'll make you a better surgeon. It's well worth it. And remember, every single week, we've got a new Cataract Coach podcast, a new Retina Rounds podcast on Apple, Amazon, Spotify, Google, anywhere you find a podcast. You find the Cataract Coach and Retina Round podcast. Plus, of course, there's a new video every single day. For Cataract Coach, we're more than 2,600 videos in a row and still going a new one every day. And now for Retina Rounds, we're coming on 200 videos. So again, check it out. And until next time, I'll catch you later.